Hi, I'm Dr. Veronica Gillispie-Bell, and I'm the Medical Director of the Louisiana Pregnancy-Associated Mortality Review. Today, I'm going to be giving you the findings of our 2017 to 2019 Pregnancy-Associated Mortality Review report. Just a little bit about maternal mortality review in Louisiana. So the first report was published in 2008, and this was a pregnancy-associated mortality review. There was not another report published until 2018, which reviewed deaths between 2011 and 2016. Now, this was an expedited review, and though it was 5 years of data, it only reviewed those deaths that were related to a condition that was related to the pregnancy, and those deaths that occurred at the time of pregnancy up to 42 days after. Since that time, we've changed how we've reviewed deaths to a full pregnancy-associated mortality review, which is reviewing deaths that occur at the time of pregnancy up to 1 year of the end of pregnancy. And we produced a report in 2017 and 2018, and now we've produced a 3-year report reviewing that data over those years of 2017 to 2019. So for the Pregnancy-Associated Mortality Review Committee, we review all maternal deaths defined as the death of an individual while pregnant or within 1 year of the end of pregnancy, regardless of cause. And we work to understand those drivers of maternal mortality, those complications of pregnancy, as well as understand where we have disparities. We determine interventions at the level of individuals, families, providers, birthing facilities, health systems, and communities, and we inform the implementation of those initiatives. Now, for our process, it does take about 2 years from the time a death occurs to when we can do the review. And it's because of the entire MMRC examination process. First, we identify cases that we think are going to qualify as a pregnancy-associated death. We then go through and verify and validate those deaths. Then, as those cases are selected, our maternal child health coordinators abstract data. Now, that data can be from medical records, it can be autopsy reports, sometimes police reports, coroner's reports. All that is compiled together to create a case narrative. The committee then sits to do a case review presentation where we review those deaths and that narrative, and then we start discussing and analyzing really what happened in that situation, if it was preventable or not, was it pregnancy related? And then the findings of the committee are entered into the MARIA database, which is the CDC's way of standardizing how maternal mortality review committees review deaths across the country. And then from there, after that data is analyzed, we create our report so that we can implement and evaluate those recommendations. Something else that I want to point out about a maternal mortality review committee, it is very diverse. It's diverse in race, it's diverse in gender, it's diverse in disciplines. And you can see that as of 2021, we had 43 members, with about half of them being clinical, half of them being non-clinical. So we have physicians, we also have domestic violence specialists, addiction specialists. We have a patient on this maternal mortality review committee, and it really allows us to give a holistic approach to reviewing these maternal deaths to figure out those areas of prevention. As a committee, there are some key questions and decisions that we have to make. First, determine was the death pregnancy related? I'm going to go through some definitions in just a minute to explain what that means. We have to determine what was the underlying cause of death, what causes death, was this death preventable, what were the factors that contributed to this death, and what specific and feasible actions can we take to prevent future deaths. So if we think about these definitions, we have this big umbrella of pregnancy-associated deaths. Again, this is the death of an individual at the time of pregnancy up to 1 year after pregnancy. Then under this umbrella, we break those deaths into pregnancy-related, pregnancy-associated but not related to pregnancy, and then pregnancy-associated unable to determine relatedness. When we say pregnancy-related, we mean the death occurred at the time of pregnancy up to 1 year of the end of pregnancy from a condition or a complication or a chain of events that were initiated by the pregnancy or aggravated by the pregnancy. Commonly, we use preeclampsia as an example. That is a condition that only occurs during pregnancy. So if that led to, for example, a stroke that caused the death, then that death would be pregnancy related. Then we have those deaths that are at the time of pregnancy up to 1 year of the end of pregnancy, but they're from a cause that's not related to the pregnancy. An example is a motor vehicle collision. The individual may have died at the time of pregnancy or up to 1 year of the end of pregnancy, but the motor vehicle collision didn't have anything to do with the pregnancy itself. And so that would be not related. Then we have those deaths where we're unable to determine relatedness. Commonly, we use suicide as an example. Sometimes patients have underlying depression that is then exacerbated because of the changes of pregnancy and postpartum depression that then lead to suicide. And sometimes the pregnancy had nothing to do with the decision to commit suicide. And so we then determine that they are unrelated, or excuse me, that they are, we're not able to determine the relatedness. Just sometimes we don't have enough information. Now, to assist us in making some of these decisions, we began using some additional tools for our review process. One is the Utah tool. As I mentioned, a lot of times when we have suicides and even accidental overdose, we don't always know if that is a pregnancy-related death. So we began using the Utah tool, which is out of Utah, that asks our case abstractors to look for certain things within the medical record. If we see those things, they get added to the narrative, and it gives the committee a point of discussion to determine if pregnancy relatedness may have actually existed for these particular deaths. Now, in about 2021, the CDC changed the Maria form, and remember that is the form that all MMRCs use to review deaths. They changed the Maria form to add a box for discrimination and bias. And while there are many deaths that we reviewed as a committee that we felt like bias and discrimination may have occurred, we really didn't have concrete evidence. So we created the LABORS tool, the Louisiana Bias or Racism and Social Determinants of Health tool. And so what it does in terms of bias and discrimination, there are things in the case narrative that are added in that we ask the abstractors to look for in the medical record. Things like excessive gatekeeping, providing care that is not consistent with the standard of care for a particular condition, leaving against medical advice. We look for things like that. And again, it doesn't mean that bias or discrimination occurred. It just helps us as a committee to have some concrete evidence if we are suspicious of that. We also know the impact of social determinants of health on outcomes. And so we began creating a social determinant of health dashboard for each decedent. And we look for different things in the geospatial social determinants of health that would indicate poverty, like the ALICE score. We look at things that would indicate access issues like the number of OBGYNs per capita, and we look at what those levels are for that decedent in that parish compared to Louisiana as a whole, and then compare it to the United States. And again, it helps us when we're making those recommendations and those points of intervention to be able to address the social determinants of health. Now, what are our findings from 2017 to 2019? Louisiana had 182 confirmed pregnancy-associated deaths, giving us a mortality ratio of 101.5 deaths per 100,000. When we break those down, we see that 44 were pregnancy-related, 114 were pregnancy-associated but not related, and 24 were pregnancy-associated but unable to determine relatedness. For those pregnancy-associated but not related, you can see that that was the majority of the deaths. That accounted for 63%, while those pregnancy-related deaths accounted for 24%. What else I think is very, very important about this data, 80% of those pregnancy-related deaths were deemed to be preventable. 83 of the pregnancy-associated but not related deaths were also considered to be preventable. And then 88% of the pregnancy-associated but unable to determine relatedness were considered to be preventable, meaning there's a lot of work that we all have to do to improve these outcomes. If we look at the leading causes of death, particularly pregnancy-associated deaths, we can see the three leading causes are accidental overdose, homicide, and motor vehicle collisions. There were a total of 31 deaths due to accidental overdose. 27 were pregnancy-associated but not related. And there were 24 deaths due to homicide, with 20 being pregnancy-associated but not related. And 23 deaths were due to motor vehicle collisions, all of them considered to be pregnancy-associated but not related. Now, if we look particularly at pregnancy-related deaths, and a lot of the data that is produced and published by the CDC, and especially looking at other MMRCs, is specifically looking at pregnancy-related deaths. We see our three leading causes are cardiovascular conditions, thrombotic embolism, and hypertensive disorders of pregnancy. And I really would argue that the three of those things are all sequelae of the same disease. Taking a deeper dive into accidental overdose and suicide, again, there were 182 pregnancy-associated deaths between 2017 and 2019. About 1/4 of those deaths listed SUD, or substance use disorder, as a contributing factor. They may not have died because of substance use disorder, but it was a contributing factor in their death. And then 1 in 3 of those pregnancy-associated deaths with substance use disorder as a contributing factor also had mental health conditions. And 100% of the substance use disorder deaths were determined to be preventable. So I think this also highlights the impact of substance use disorder, not only in our overall number of pregnancy-associated deaths, but just the impact it is having on deaths in general, but also mental health conditions. Again, taking that deeper dive, when we look at those number of suicide and homicide deaths, 26 had a history of substance use disorder, 12 had child protective services involved, 11 had unemployment. And so we start to see those social determinants of health and how they are impacting those outcomes and also contributing to those deaths. So again, that history of social and emotional stress are huge contributors to those accidental overdoses as well as suicide. Now, when we look at racial disparities, I think this slide illustrates it in a way that makes it very easy to see. 37% of all births in Louisiana from 2017 to 2019 were to non-Hispanic Black mothers. However, non-Hispanic Black mothers accounted for 57% of the deaths. So again, 37% of the births, but 57% of the deaths. And so that gives us a disparity of 2 Black women dying at a rate of every 1 white woman. Now, if we break that down into pregnancy relatedness, for our pregnancy related deaths, it's 2.5 Black women to every 1 white woman, with the leading causes being thrombotic embolism, hypertensive disorders of pregnancy, and cardiovascular conditions. And then if we look at pregnancy associated but not related, it's 2 Black women for every 1 white woman, with the leading cause being homicide. We see disparities not only in race, but also in education. Women with a high school degree, GED or less, accounted for 47% of the births in Louisiana, but 68% of those pregnancy-associated deaths. So again, seeing that disparity, now thinking about our social determinants of health. If we look at insurance type, we don't actually see a disparity, but we see an opportunity. 60% of the women who died within a year of pregnancy, so in that pregnancy-associated deaths, had Medicaid as their insurance provider. But during that same time, 61% of the women that gave birth in Louisiana had Medicaid as their insurance provider. So again, we don't see a disparity, but that's an opportunity. Medicaid is the biggest healthcare provider for our pregnant patients in Louisiana. So that provides an opportunity to ensure high quality care before, during, and after pregnancy, as well as improve coordination of care. Looking further at maternal demographics and looking at age, we can see that the ratio of pregnancy-related deaths increase with age, which is understandable because as we get older, we have different chronic comorbidities that would increase our risk of death. And then the rate of pregnancy-associated but not related deaths was highest in the 30 to 34-year-old age group. I think that this slide is very important. This shows the timing of deaths. So you can see the majority of deaths, regardless if we are talking about pregnancy-related, pregnancy-associated but not related, or unable to determine relatedness, the majority of those deaths actually occur after delivery. You can see for pregnancy-related deaths that 61% occurred within 42 days of pregnancy, whereas 16% occurred from 43 days up to 1 year. So 77% of pregnancy-related deaths occurred after pregnancy. I do think we're seeing a decrease in this number. I would like to believe we're seeing a decrease in this number of deaths while pregnant from pregnancy-related conditions because of the work that we're doing through the LAPQC to increase readiness and response in our birthing facilities. Also speaks to an opportunity, and as Louisiana being the first state to extend Medicaid to 1 year, will have an increased access to insurance start to improve these outcomes. Now, when we look at our deaths, we then look at contributing factors on different levels. We have the patient family level, system level, provider, facility, and community. Patient family means an individual before, during, or after a pregnancy and their family, internal or external to the household, with influence over the individual. For systems, we mean those interacting entities that support services before, during, or after pregnancy. And that ranges from healthcare systems all the way to public health agencies. Provider is an individual with training and expertise who provides care, treatment, and or advice. And then a facility is a physical location where direct care is provided. And that can range from a small clinic like an urgent care all the way to a big healthcare center that has trauma care. And a community is a grouping that is based on a shared sense of place or identity, and that ranges from a physical neighborhood to a community that's based on common interests. Now, when we look at contributing factors and the deaths from 2017 to 2019, patient and family was the leading contributing factor. Not that we're blaming patients or family, but that did contribute to those deaths, and really in 3 different areas: non-adherence with medical care, substance use disorder, and then lack of knowledge. For systems, we saw a lack of coordination of care, lack of standardized policies, and then barriers to accessing care. And then providers, we saw failure to screen, misdiagnosis, or failure to seek consultation. When we look at patient and family and system, what is screaming to me is social determinants of health. Now, for our recommendations and prevention. First, it's important to understand that there is something that everyone can do to decrease maternal mortality. Everyone can support healthy behaviors and healthy habits such as exercising, not smoking, healthy eating habits. Everybody can know when to seek help and know when to seek care. We do a lot of this work with our birthing facilities, making sure that families know those post-birth warning signs. Everyone can recognize that implicit bias and structural racism are at the root of the disparities that we see and start to address those biases. Everyone can understand the prevalence and impact of substance use disorder, remembering that that is our leading cause of pregnancy-associated deaths, and that 1/4 of our deaths had substance use disorder as a leading factor. And so as we understand that, what can we do in our communities to not only prevent substance use disorder, but risk mitigation strategies, risk or harm reducing strategies, having access to Narcan if you have a family member that you know is using substances. And then with our social determinants of health, we all have to address the conditions in which people live, work, learn, play, and age. Now, for our recommendations in the report, we do make recommendations by point of intervention, healthcare professionals, healthcare systems, social local community, policy makers, healthcare systems, and then also those public health researchers. Now, and I'm sorry, with those healthcare systems, that should also be with our payers. And so we make these points of intervention and recommendations by points of intervention. I will not go through all of the recommendations because it's 12 pages, but I'm going to go through what those priority areas are for prevention. First is improved care coordination before, during, and after pregnancy, including support for continued health care during the 4th trimester. As you heard, care coordination on a system level as well as provider level was one of those main contributing factors. And as you saw, the majority of our deaths actually occurred after pregnancy. So we need more support in that 4th trimester. We have to ensure pregnant people receive the appropriate level of care based on the complexity and severity of their medical issues and their risk factors. So making sure that we're getting patients to the right care at the right time. And a lot of that, again, is focused on readiness in our birthing facilities. We need to expand the obstetric healthcare workforce through telehealth. We know healthcare access, transportation is a barrier, and so we need to look at other ways to bring care to the patient instead of making the patient come to care. And we have to remember that we need specialists such as cardiologists, psychiatrists, behavioral mental health specialists, hematologists. We have to think about the obstetric healthcare workforce being more than just obstetricians. We have to address racial and cultural bias across the network of care that serves pregnant and postpartum individuals. Again, we know that implicit bias and structural racism is at the root of all disparities. We have to improve and expand the identification of and treatment for substance use, as well as mental health during pregnancy and after pregnancy as well. We have to increase the awareness of the Louisiana Pregnancy-Associated Mortality Review Committee and the work that we're doing, and support the need for data sharing. While we do the best we can to get access to as much information as we can, we do have roadblocks, and so it does make it difficult to complete the review if we don't have access to all of the information that we need. And then we all have to contribute to the public health evidence base to increase our capacity and better understanding and address pregnancy-associated mortality. Now, how do we in the Louisiana Department of Health use data for action? So there's state level efforts to reduce maternal mortality. And in the Office of Public Health, there's 3 focused interconnected areas: monitoring maternal outcomes, supporting clinical and systems change, and then supporting policies that support a strong system of care. For our maternal outcomes and monitoring those, we do that in several ways. One is through the Louisiana Pregnancy-Associated Mortality Review, our Maternal Mortality Review Committee that we've been discussing, and then also through the Louisiana Pregnancy Risk Assessment Monitoring Program and the Injury and Violence Prevention Program. These are our arms of surveillance. And then we have a lot of initiatives and programs that support clinical and systems change. And so just speaking of a few, or mentioning a few right here, we have our Louisiana Maternal, Infant, and Early Childhood Visiting Program. And so this is doing home visiting for individuals that are pregnant up to several years after the child is here, as well, and that's through our Nurse Family Partnership Program, as well as our parents as teachers. Through the Louisiana Perinatal Quality Collaborative, as we've already discussed. This is a voluntary network of perinatal care providers, public health professionals, patient community advocates, all working to advance equity and improve health outcomes for our women in Louisiana, as well as our families and our newborns. And specifically, we've worked on several initiatives. One, the Reducing Maternal Morbidity Initiative, which was focused at improving readiness and recognition for hemorrhage and hypertension. We also have now our Safe Births Initiative, focused on implementing other bundles, AIM bundles, patient safety bundles, as well as reducing the low-risk C-section rate. We have our Improved Care for the Substance Exposed Dyad Initiative, which is focused on substance use, opioid use disorder, and best practices for the dyad of the mom and the baby, as well as addressing stigma and bias for those individuals. And then we have our Caregiver Perinatal Depression Screening Pilot, which is a pilot in pediatric practices focused on implementing the Bright's Futures from the American Academy of Pediatrics recommendation to screen caregivers at the well child visit at 1 month, 2 months, 4 months, and 6 months. We also have the Louisiana Mental Health Perinatal Partnership Program. This is a partnership that provides consultation, provider-to-provider consultation for licensed healthcare clinicians serving pregnant and postpartum patients. It supports healthcare clinicians to address the needs of their patients for perinatal depression, anxiety, substance use disorder, interpersonal violence, and other health-related conditions. And then the Reproductive Health Program is the state's sole grantee of the Title X Family Planning Service Grant. It is the only federal program that is dedicated to providing access to high-quality contraceptive services, supplies, and information to anyone who needs them or wants them. And it administers this program through our statewide health parish health units, and there are 60 of those, as well as different community health centers. And those policies that we have that enable that support of a strong system. We have Healthy Moms, Healthy Babies Advisory Council. This was through Legislative Act 497. It formed this committee to start addressing some of the same things that we've discussed around maternal mortality. And those key findings were published in a report in March of 2021. Because of HR 294, we had a huge maternal mortality summit in August of 2019. And this summit involved not only local leaders, but also national and international leaders. Realignment of hospital licensing standards for levels of maternal care. One of those points of intervention that we discussed, or one of those areas of intervention, is making sure that patients get to the right care based on their acuity. And with that meant strengthening our system of care so that we more closely align with national recommendations for our levels of care. Act 320 established a domestic violence fatality review so that we're getting putting a deeper dive into domestic violence. And Act 182 established the Louisiana Doula Registry Board so that we can start a registry so that doulas can be insured by insurance companies so that they will be a coverage service and available to all. Thank you so much for your time. If you have any questions or other information that you'd like to know about the Pregnancy-Associated Mortality Review, please feel free to reach me at veronicagillispie.la.gov, and please visit us on the Partners for Family website for the entire report, as well as some one-pagers. Thank you so much.